When you came back here from Canada, you were coming at a time, of course, when there had been these huge controversy about the concept of these centres of excellence. Describe the landscape when you got here and where you want to take it.
Certainly. When I first arrived, I already benefited from the very well-developed national strategy and the fact that my colleague and very good friend Tom Keane, who had also come from Vancouver and British Columbia, had been here ahead of me for about 2.5 years. So he had actually implemented the major steps at the beginning of that strategy. And Tom took a very rational approach. He said, we've got to fix the surgery first and then the radiation. We've got to concentrate the services in the designated cancer centres. And subsequently, we will deal with all of the other elements of cancer as time goes by. So when I first arrived, there was still some lingering concern, particularly in smaller communities and towns, that they had lost something because breast cancer services had been consolidated. Rectal cancer services were largely consolidated. Lung cancer, I think people rather accepted that going to 4 big centres made sense. Prostate cancer, again, we're still finishing off the job of consolidating services, but we've done most of the work there. So I think I came in after the major concerns that had been evident around 7 to 10 years ago, where the big emphasis then was on poor outcomes, misdiagnosis, delayed diagnosis, poor access to care, and a significant level of concern in the country that despite the fact governments had invested in funds for cancer and excellent doctors had been hired, the organisation of the cancer services hadn't come together in the earlier part of this current decade. Now that that's been achieved, certainly my job was much easier because the designated cancer centres had been established. I then inherited the good work that had begun on the breast symptomatic clinics, where GPs in primary care can refer in women who have a concern, whether it be a lump or whether it be some other related issue, and they're guaranteed that if it's urgent, a woman is seen within 2 weeks, and then if it's non-urgent, within 12 weeks. Those women get triple assessment in terms of mammography, ultrasound if need be, biopsy if need be, a multidisciplinary discussion if anything worrisome is discovered, and very prompt surgery. That had already been started, but at that point was only in its 2nd year. So I've seen that service evolve brilliantly now, and the big change that I've seen is how the multidisciplinary teams, particularly the radiologists and the surgeons who are very busy in those particular areas, are now coming together nationally, and they really work as a national team as well, which is unique in Ireland, where people tended to work in their hospitals, in their disciplines, but not necessarily as part of a bigger team. So we've seen continuous improvement in service delivery, but also refinement in how to treat people or how to diagnose people in that service. Then based on that learning, just as I was arriving, and one of the last things that Professor Keane did is he implemented lung cancer rapid access clinics in 8 hospitals and prostate cancer rapid access clinics, which were barely starting as I arrived. And they have turned out to be remarkably successful. So if a GP thinks a man or woman might have symptoms or chest x-ray suggestive of lung cancer, they're seen very promptly, and we're finding now that there's 2,500 to 3,000 men and women going through those clinics every year, and 1/3 of them are diagnosed with cancer. Prostate rapid access is more about getting to a rapid opinion, not necessarily rapid treatment, because men need to reflect on their treatment options. But those clinics are seeing up to about 3,000 men a year in 8 centres, and about 40% of them are diagnosed with cancer. So we've learned how to expand it to other areas, and we've learned very well. The other aspects of care for the well population that have really developed over several years was initially the National Cancer Screening Services were started off under the national leadership of Tony O'Brien, who is now the Director General of the HSE. And he took the Eastern breast check services and expanded them nationally. But on my watch, because I arrived in October 2010, the first national sweep of the entire country was accomplished in 2011. We're now on to our second round across the country, and we're absolutely delighted that we have a highly effective breast check service. Likewise, cervical screening is well embedded, but the big excitement for me in the last 3 or 4 months has been the implementation of the bowel screen program, which is our national screening program for bowel cancer, which will take 3 years to do its first sweep of the country, where people between the age of 60 and 69 are invited to volunteer to do a test at home. It's a stool test. They send it into a designated lab, and if they're found to have any blood in their stool, they are referred on for colonoscopy. And we have set up a very complex program to diagnose those patients. It's just in its beginning steps right now, and as I said, it will be 3 years to scan the whole country, to screen the whole country. After that, we'll be screening every 2 years and eventually expanding the age range. So that's been very exciting. Getting back to not the well population being screened, but the symptomatic patients who are diagnosed with cancer, the other big changes has been the rapid expansion of sophisticated radiotherapy services across Ireland. So again, in 2011, 2 brand spanking new radiation oncology centres were opened as part of the St. Luke's network. We have the original St. Luke's Hospital. We have the 2 St. Luke's network centres that have been added, and we're sitting in one today at St. James's Hospital, and there's an identical one at Beaumont Hospital. And these centres offer very sophisticated radiotherapy, very much built around intensity modulated radiation for selected groups of patients, where the beams are focused through complex software to limit any injury to surrounding tissues in some cancers. Not every cancer, you don't need it for every cancer. But that has been a big step forward. We are opening more stereotactic radiotherapy, and you'll hear more about that in a few weeks' time, initially for people with cancers that have spread to their brain, but ultimately for patients who have cancers in other parts of their body. We have extended prostate brachytherapy from its excellent startup centre in Galway, where Galway has been the lead hospital, and now it's available in St. Luke's, in Dublin, and in Cork University Hospital. So we're delighted for men. There's now a broader range of treatment options for newly diagnosed prostate cancer. And then on top of that, I think one of the most exciting areas of new technology and development is cancer drugs. And we're now in a maelstrom of information about molecular elements of cancer and the genetic abnormalities underlying cancer. And the pharmaceutical industry has been very industrious internationally in developing new drugs that target cancer in a way that can personalize the treatment for different cancers. This approach is still in very early development in the human setting, but is very advanced in the laboratory setting. And we are now seeing a range of new drugs coming through, approved for use in patients, that are very focused on patients who have cancers with very specific abnormalities. That is a dramatic change, and it will continue to change. And furthermore, I know that the pathology underpinning it, the diagnostic tests, are another area of rapidly developing very sophisticated analysis of a cancer to tell if it's suitable for a whole battery of potential new drug innovations. So that will be, I think, the biggest area of development over the next decade or several decades, and I think we'll see a lot of progress. Now, we can see some changes in breast cancer. That's the commonest cancer that you can actually see survival improving in Ireland. It only in the early part of around 2000 to 2002, patients diagnosed in that era, you would find that about 76% of them were alive 5 years later. If you take another cohort of patients diagnosed around 2005, 2006, and our National Cancer Registry, which is an excellent cancer registry, has done this work, has already demonstrated that now nearly 80% of them are alive 5 years later. To shift a population survival by 4 or 5% is actually a huge impact. And I anticipate it's multifactorial as to why that happened, before services were re-engineered. And I think it was the gradual expansion of somewhat informal screening programs in Ireland, and it was also the graduated introduction of highly effective new drugs in the early treatment of breast cancer. And on top of that, I think in general you had a more educated population who understood about cancer better, and GPs were quicker off the mark in diagnosing it. So all of these elements came together to show some improvement, but there is room for another 10% improvement to catch up with the best countries. That's a huge jump, and I'm hoping that we're nearly there, and we'll find out when we do the analysis a few years from now. Targeted therapies are treatments that specifically tackle one particular focus within the cancer cells, and they comprise some of the most highly successful new treatments that have ever been developed. A classic one we've heard a lot about is Herceptin, and Herceptin targets a particular growth factor which is mutated, called HER2/neu in the cancer cells, most typically in breast cancer. This particular targeted therapy can not only enhance cure in newly diagnosed patients, but it can really prolong life by switching off cancer growth in women with advanced breast cancer. So that is a breakthrough drug. Another breakthrough drug is Gleevec, otherwise known as imatinib, which is dramatically effective in chronic myeloid leukemia and another rare cancer, which is a gastric stromal tumor. It's transformed the lives of people with those two cancers in that it can control disease for many years. So that's fantastic. Another brilliant targeted drug, rituximab, which is a drug for lymphoma cancers. These are white blood cell cancers, and this targets the CD20 marker, a biological marker in B-cell lymphocytes, and it not only dramatically improves cure rate when given in conjunction with chemotherapy, but can also prolong life as a single agent. Interestingly enough, rituximab and Herceptin are most effective either given with or after chemotherapy, so there's an additive benefit. And we must never forget that one of the best ever targeted treatments was targeting the estrogen receptor in breast cancer with anti-estrogen drugs such as tamoxifen, which have been around for 40 years. So targeted therapy has been around a long time, but it's now exploding as a new area where there are many new targets being identified through all of the work in identifying the human genome and the molecular products of these genes.
So let's talk about genetic screening and actually identifying people at risk of cancers, diagnosing kind of the risk of cancer much earlier.
Well, I'm delighted you've asked that question, because an area of focus for the National Cancer Control Programme is to develop greater access to genetic services to identify the well population at risk. But before I talk about that, I do want to emphasize to the people who might be watching this programme that, first of all, although cancer itself is due to a change in a gene in a cancer cell, a genetic mutation that's gone wrong, please don't think that that means that all cancer is inherited. This is a very common misunderstanding. Only a small minority of cancers arise in people who have a hereditary risk, where there's a history in the family of a specific type of cancer or a specific family of cancers arising, usually at quite a young age, and that triggers us to think there's something different in that family. So for breast cancer, somewhere in the range of 5 to 10% of people diagnosed with cancer might have an inherited risk in that individual patient. For ovarian cancer, for a particularly aggressive type called serous poorly differentiated ovarian cancer, the risk may be as high as 20% that it's inherited. And then in a number of families with colon cancer, there may be a hereditary gene, as well as in some rarer hereditary abnormalities such as P53 Lee-Fraumeni syndrome. So without me getting into some of the rarer issues, I'd like to focus on what we're endeavouring to do in Ireland to be able to make diagnostic services for hereditary cancer more broadly available. And first of all, I really would like to say how much we've appreciated the substantial work that's already been carried out by Professor Andrew Green from the National Medical Genetics Centre based in Crumlin. He not only does paediatric screening for genetic problems, but he has run a cancer screening service in Ireland for a number of years and done it very well. However, there's a lot of unmet need that's been identified, and waiting lists were developing because we needed more people to engage in assessing patients. So now we have established services through medical oncologists who have some specialty genetic training in St. James's, in the Mater, and just very recently we're getting going in Cork. In addition to Professor Green's services, which provide outreach support to Cork and Galway, as well as consultations in Dublin. So we're partnering with Professor Green to build capacity, and the way we're moving forward now is we're making it much easier for patients who themselves have been diagnosed with cancer, who have a strong family history, to be seen very promptly in the designated cancer centres that have this service. Not all centres have this service. It's very specialised. There are very few people in the country that can screen the patients, and we also have genetic counsellors in Professor Green's service that work collaboratively on this. So we're scaling up access to these services, and once a woman has had a blood test after she's given consent and been informed, then, and if we've detected a genetic mutation, and the commonest ones are BRCA1 and 2 in breast and ovarian cancer, we can then say to that patient, if you have family members who wish to have a discussion with our counsellor about what testing means, we can then invite them to come for testing. And we will invite those individuals for a discussion, usually with a genetic counsellor or perhaps with a doctor, and they will then understand the pluses and minuses as to whether they wish to be tested or not. A few people would rather not know. A lot of people would really like to know. And if they choose to have a blood test and are found to have a genetic mutation, then we put in place a surveillance program that monitors their course. And we have periodic discussions about surgery, because surgery is the best prevention. Now, it is pretty much, it's hard to take for a young woman who's found to have genetic mutation like BRCA1 and 2 to know that your best prevention is to have your breasts removed and your ovaries removed, because they may wish to have their families, of course, and they may have real concerns about having surgery that can be cosmetically or psychologically bothersome, to say the least. So once people have finished their families, they may view that option very differently, and it's becoming very popular in the United States, for example. For the people who don't want to have anything done surgically, they are under careful surveillance with MRI scans annually of their breasts. They have routine assessment of their risk of ovarian cancer, but to be frank, our ability to catch it early is low. So that is a bother. And they're minded. Likewise, for families with colon cancer risk, if you have a genetic mutation, then you are offered very careful surveillance with colonoscopy. Or if you have familial multiple polyposis, you're usually offered surgery, which is quite radical, having your colon removed. So there's a whole series of different discussions that have to take place. And we certainly want to, as a very minimum, offer careful surveillance. So we still think there's some unmet need in the country. We still have some modest waiting lists for an elective test, but we are gradually escalating our investment in the tests themselves and in the staff with the expert skills to be able to offer this service. I should probably mention too that we invited HICWA now nearly 2 years ago to do a technology review assessment of what is the best surveillance for people with these genetic mutations, and they only reported in on their very sophisticated and detailed analysis a week ago. So we're taking that on board now. The women who are at high risk and some men, we think are already, for the most part, being followed in our breast symptomatic services or in familial cancer clinics, but we want to now take that information and develop it as a more formal surveillance program that will take us some time to develop. But I think we're well positioned to do that.